Hello everyone and welcome to this LRF Facebook live chat. We have an awesome live event for you here today. We are inside the lab at the Memorial Sloan Kettering Cancer Center, and we are going to have a chat about immunotherapies and the latest in some cancer research when it comes to lymphoma. All of that cutting edge research being done right here in Manhattan at Memorial Sloan Kettering, and we are very fortunate to have two amazing doctors with us today to talk about this. Dr. Andrew Zelenitz and Dr. Leah Palumba, both of the Memorial Sloan Kettering Cancer Center. Thank you so much, doctors, for being with us today.
It's our pleasure.
So for the people at home who might just be discovering lymphoma for the first time, what is lymphoma and what do they need to know?
So lymphoma is a primary disease of the lymph node. It's not really a disease of the lymph node, it's a disease of the lymphocyte. When a lymphocyte becomes malignant and starts to reproduce itself and expands as a clone, that is a lymphoma. Lymphomas frequently involve lymph node, but they can involve virtually any site in the body, including skin, brain, eye, the gut. It's because lymphocytes, the cells that give rise to lymphoma, are in fact traveling cells. This is what they do. That's why we never talk about metastatic lymphoma. There's no such thing. It's because lymphocytes are designed to travel, and we find lymphocytes in all tissues of the body, and that's why we can see lymphoma develop in all tissues of the body.
And so with that being said, how common is lymphoma?
There are about 70,000 cases of lymphoma a year in the United States. There are about 80 different types of lymphoma, depending on how you count. But if you look at the World Health Organization characterization of lymphomas and you count the different entities, there are about 80 different types. Fundamentally, we divide lymphomas into their cell of origin, so whether they're B-cell lymphomas or T-cell lymphomas, and then the occasional NK lymphomas. Those are pretty rare. And in the United States, about 85% of all lymphomas are derived from B cells. The B cells are the cells in our body that supposed to give rise to antibodies, and will differentiate into cells called plasma cells that then help protect us from certain types of infections, particularly bacterial infections. The T cells are the cellular immune cells of the body. But they too can give rise to lymphomas. In different parts of the world, we see different distribution of lymphomas. In Asia, there's much more T-cell lymphoma than in the United States. We also see what we call aggressive lymphomas. The most common lymphoma in the United States and actually around the world is diffuse large B-cell lymphoma. In the United States and Europe, the next most common lymphoma is follicular lymphoma, which is a relatively slow-growing lymphoma. This is really rare in Asia. It comprises of less than 10% of the lymphomas in Japan and China, whereas in the United States, it's about 25 to 30% of the lymphomas.
So it's pretty unique as far as which type of lymphoma is more prevalent around the world.
Correct.
So, Dr. Palumba, one of the words we hear a lot when it comes to cancer research and treatment is the word immunotherapy. What is immunotherapy and what do people at home need to know?
So immunotherapy is the use of the immune system to attack the lymphoma cells. And there are fundamentally two different types of immunotherapy. There is what we call passive immunotherapy and active immunotherapy. Passive immunotherapy is when we take, for instance, a monoclonal antibody and we give it to the patient and we just let that antibody attack the cells. Active immunotherapy is when we actually try to stimulate the patient's own immune system to become active against the lymphoma, which normally would not be recognized by the immune system because cancer cells have ways to hide from the immune system. So we have methods to basically try to unleash that immune system that is normally not functioning and make it functioning again.
I think that word monoclonal might be scary to some people at home. What does that mean so that they get an idea of the actual things that are happening inside their bodies?
So monoclonal means deriving from a single clone. A clone is basically the so-called mother cell. So let's say we're talking about a clonal process. So lymphoma is a clonal disease. That means that there was a cell, the original cell, that divided when it became neoplastic, so cancerous. It divided and gave rise to a bunch of daughter cells, and that group of cells is called a clone. So a clonal disease is a disease that is derived from an original mother cell.
And then when we talk about monoclonal antibodies,
yeah.
well, they're the same thing. They're an antibody derived from a single cell. In the old days, we made mouse human hybrids, and we fused the cells together, and the cell would then produce the antibody, and we would screen for the antibody that we wanted it to react to. But because the antibody was derived from this clone that was expanded, it was called a monoclonal antibody. And so it's a little different. There's clonal disease, which is the lymphoma, but the monoclonal antibodies are simply meaning that they're derived through a process where we are identifying a specific target, and it's a single clone of antibody that is then grown, and now in industrial scales in huge fermenters of thousands of liters at a time.
So I really want to go over this because I think this is my understanding of it. And correct me if I'm wrong, which happens a lot, and I think a lot of people at home sometimes get information wrong here. So when you're using these immunotherapies, in some cases, are you basically teaching the immune system within a person to identify certain aspects of the cancer cell so that their immune system is able to identify those cells inside their bodies?
Well, this is getting back to what Leah was talking about, and that's the question of active immunotherapy versus passive immunotherapy. So active immunotherapy is, in fact, to try to re-educate, or in some cases, intentionally redirect cells of the immune system to do things they don't normally do, like in CAR T cells. We're going to talk more about that later, don't worry. So active immunotherapy is exactly that, trying to make the immune system work against the cancer. But there is a very, very important form of immunotherapy, which we call passive immunotherapy. In fact, passive immunotherapy was first approved for treatment of lymphoma in 1997 through the drug rituximab, and remains the most important immunotherapy ever created by man. Why? Because it has fundamentally changed the survival of patients diagnosed with B-cell lymphomas. We are hoping some of the active immunotherapies will be able to say the same thing, but these are still early days. We're now really well into the passive immunotherapy era, and we know we have made enormous contributions to longevity of patients with B-cell lymphomas.
You mentioned rituximab. What are some of the other drugs that have been developed that patients might be familiar with or might hear as they go to the doctor's office right now as far as immunotherapy treatments?
Well, there are different. So the target of the monoclonal antibody rituximab is CD20, and so there are other CD20 antibodies that have been developed in trying to make the antibody more active. And so, Andy, you are the expert in this, and
so
I
there
want you
are
to talk about
three approved anti-CD20 monoclonal antibodies: rituximab, ofatumumab, and obinutuzumab. I know the ofatumumab and obinutuzumab sound a lot alike. There actually are different drugs. Rituximab is an excellent antibody. It works very well clinically. But if you're designing a drug, it has certain features, and gets awfully technical, but when it binds to the CD20, it tends to want to come off. It doesn't want to stay bound very tightly. If you have a lower what's called off rate, the antibody might be more effective because it stays on the target longer. One of the ways that rituximab works is that it initiates recognition by T cells and NK cells and actually neutrophils in a process called anti-dependent cell-mediated cytotoxicity. And this process is very important for the way the antibody works. And rituximab is pretty good at doing ADCC, which is the short way of saying antibody-dependent cell-mediated cytotoxicity.
You can say that 3 times fast.
So the different newer antibodies have been engineered to do different things. So the third way to kill cells, so there are 3 ways that an antibody kills cells. It kills directly, which is called induction of apoptosis or induction of cell death. None of them do this super well, although obinutuzumab probably does it better than the others. Then there's ADCC. And then the third way that is that the antibody binds to the cell and then it recruits proteins and does what's called fixed complement. And these proteins that are recruited to the antibody then create an attack complex and lyse the cell. And ofatumumab was designed saying, oh, the most important mechanism is complement-mediated fixation. There's almost no ADCC with ofatumumab. It's entirely a bet on complement-mediated fixation. It's probably the wrong bet because it is the weakest of the 3 antibodies across the board, not only in CLL but also in lymphomas. Obinutuzumab was a bet that you needed to ramp up ADCC. It has several engineering little twists to make that happen. And there's no question, in the test tube, on the bench,
here where we are in MSK's lab,
you're going to, if you say which one I'm going to take clinically, and we had an approved, and we had rituximab in one bottle and we had obinutuzumab in another, we would have unequivocally chosen obinutuzumab. Why? Because it looks so much more potent. However, funny things happen when you get to a patient, because we've done head-to-head comparisons of rituximab and obinutuzumab in a number of clinical situations. In CLL, I'm convinced it's clearly a better antibody. There are so if you take rituximab and chlorambucil, and you take obinutuzumab and chlorambucil, you compare them head-to-head, there's an overall survival advantage for the patients who got obinutuzumab. That's a pretty good argument that it's a better antibody in CLL. Then you got a large cell lymphoma, a very good trial, obinutuzumab and CHOP versus rituximab and CHOP. Guess what? No difference, nothing. And then you get the in-between result. You do the same thing in follicular lymphoma, and guess what? Obinutuzumab's a little better, but it's not as slam dunk. So what we design in the laboratory and the bets we make about how to make a better antibody doesn't necessarily translate. Now, what does that mean? It means that we're still lacking some knowledge about how these antibodies really work and what they're doing. But at the same time, in some circumstances, obinutuzumab is clearly a better antibody. Well, and so it is an advance for certain patients.
While we're on this topic, because we get a lot of questions to the Lymphoma Research Foundation helpline about rituximab versus obinutuzumab, you mentioned some of the different cases. How do you advise a patient on which one they should be using if it's available to them?
So in the United States, obinutuzumab is actually available to anyone who has follicular lymphoma or chronic lymphocytic leukemia, because it's approved for both indications. Obinutuzumab is slightly more difficult to use. You have to have a little bit, like every drug. I mean, rituximab was hard to use in the beginning. It's pretty trivial to use now. But it has a little bit more of an infusion reaction. It tends to cause lower blood counts, so you have to be aware of these problems. So many clinicians say, well, the differences for follicular lymphoma are not so great, so I'm going to stick with rituximab because it's a little bit safer and the differences aren't that major. Whereas I think in CLL, in certain circumstances, obinutuzumab is the better antibody, but in CLL, there's a whole nother story. Things are evolving to small molecule treatments, and the role of upfront antibodies might be changing not now, but in the next year or two.
Did you want to add something to that there, Dr. Palmer?
No, I agree. I think that there is a lot of individual difference in the way we treat these lymphomas, and a lot of physicians are just more comfortable with a certain regimen. And given the very small difference in activity, particularly in follicular lymphoma, they would just feel that they've given rituximab bendamustine for the past 10 years and it's worked well, and they feel it doesn't have too much of a toxicity profile, so why change now to gain a small difference in progression-free survival and add maybe a little bit more toxicity. So it's very, I think there isn't really a better way to do it, because in the end the response is quite similar.
So let me ask you, when it comes to both of these treatments and other immunotherapies, how are they administered then for the patients?
So antibodies tend to be administered intravenously. There is a preparation of rituximab that can be given subcutaneously. And that's another reason why some physicians might choose to use rituximab over obinutuzumab, because patients love it. You know, it's a 10-minute infusion under the skin, and they have a little bit of soreness for a day or two, but they're out of there instead of being in the chair for anywhere from 90 minutes to 3 hours. Everyone still has the first 3 to 6 hour initial infusion because everyone starts with the intravenous form. But being able to switch to that subcutaneous form, you know, is a big benefit for a lot of patients.
Yeah, do you see the same thing as well, Dr. Palumbo?
Yes, absolutely.
As far as the patients are concerned.
Yeah.
What are the drawbacks then for the obinutuzumab that maybe patients would likely steer away from that?
Well, there's a little bit more infusion reaction, though. I think many of us have figured out how to completely minimize it. I've actually have not had a serious infusion reaction in a couple of years. But it definitely causes more low white blood cell counts. So when you combine it with chemotherapy, you have to be much more careful about the white blood cell count. And we tend to use more growth factors, pegfilgrastim or filgrastim, with obinutuzumab combinations with chemotherapy than with rituximab, simply because there's unequivocally a little bit more neutropenia associated with the obinutuzumab.
I just want to do a little research for people at home as you're coming and going. Right now you are watching a Facebook Live presentation by the Lymphoma Research Foundation. We are at the Memorial Sloan Kettering Cancer Center here in New York City, and we have Dr. Zelenich, who only has a few more minutes, who's going to be with us, and Dr. Palumbo, who are talking about immunotherapy and the research being done here at MSK. So with all of this that we've been talking about when it comes to immunotherapy, what are the biggest differences of immunotherapy versus other treatments that patients may receive? Dr. Palumbo?
So immunotherapy is really the staples of B-cell lymphoma. So we practically always start with something that contains immunotherapy, some regimen that contains a monoclonal antibody.
What's the reason for that?
It's just a standard of care. It might change for some lymphomas, particularly for CLL. It might completely change in the next few years. But right now, that's the standard of care, the proven treatment.
But the standard of care arose because patients lived longer when you added rituximab or obinutuzumab to chemo compared to chemo by itself.
Yep.
So, it didn't become a standard because, we think it's a cool thing to give. It's because carefully done clinical trials have proven that this has a prolonged benefit that improves people's survival.
I want to talk about clinical trials for a second, because you mentioned how patients are very happy with the rituximab and because of the nature of the care. When it comes to going and convincing patients to become a part of clinical trials, why is that so important to furthering the research and treatment of these cancers, especially considering we're at a place right now like the lab at Memorial Sloan Kettering?
Well, I just said it. Okay, so
yeah.
If I add,
let's study.
if we had not done the clinical trial to give half the patients chemotherapy and half the patients chemotherapy plus an antibody, we would have never proven that adding an antibody improved people's survival and has now become the standard of care. the way we improve the standard of care is through clinical trials. And in many circumstances, we really don't have a defined standard of care. You're going to hear a lot about CAR T cells later. And one of the things is in the relapse setting of aggressive large cell lymphoma and other relapse lymphomas, we're not getting cure rates of 65, 70% like we are in first-line diffuse large B-cell lymphoma. And, so the clinical trials that help us improve the treatments are actually, I believe, in fact, the standard in many situations where you don't really have a good alternative. You have something that you could do. It doesn't mean that the clinical trial should wait until after something you can do. Oftentimes, the clinical trial is the right thing to do even before, there might be another treatment I could try, but we know what's going to happen with that other treatment. It'll work in some patients. It might work in a patient it works. It might work for a period of time, but we really want to improve the outcome of these patients, and that's how we do that with clinical trials.
Excellent. And Dr. Zelnitz, I know you are on a tight time crunch. We really appreciate your time here today for answering these questions, but we'll let you go now as we will shift over to CAR T-cell therapy and talk a little bit about that more. But thank you so much for your time today. Really appreciate you being here.
Thank you. Have fun.
So, Dr. Paloma, being that we are here at the Memorial Sloan Kettering Cancer Center, we talked a little bit about clinical trials there. The work being done here is actually pre-clinical trials, correct?
In this particular lab and in all the labs in this building and other buildings at Sloan Kettering, we do preclinical work that leads to the development of drugs. And CAR T-cell therapy is basically a new type of drug. It's a live drug, but it's a drug.
All right, and this is awesome. We actually have the opportunity here to show you how some of this process goes. So if you don't mind leading us over there, we'll head to that area of the lab. Now, as we're heading over there, if you could just tell us what exactly is CAR T-cell therapy and what do patients need to know? So
CAR T-cell therapy is a type of immunotherapy that is done using the patient's own cells of the immune system. So the immune system is composed of B cells and T cells and some, as Dr. Zelnitz said earlier, some other cells that are in much lower proportion, the NK cells and myeloid cells. But the B and T are the biggest ones. And so what we can do is we can take the T cells out of a patient's body, modify them in the lab, in a lab like this, but obviously certified to do clinical work, and then reintroduce them in the patient's body. And the modification consists in inserting in the T cells a protein that is a chimera. So if you remember from your Greek, chimera means made of multiple parts, right?
You called it the Frankenstein.
Or Frankenstein. Yeah, Frankenstein is another great way to define it, because really you're taking pieces of proteins and put them all together to make a new protein that never existed before. So this was a great concept that comes out of Memorial Sloan Kettering, UPenn, the NIH, and the Hutchinson in Seattle. But basically, you make this big protein, and the idea is that this protein has a part that recognizes the lymphoma cells, so it's able to take the T cell that is transfected with that protein and bring it in contact with the lymphoma cells. When that contact happens, the other part of the protein, which is now inside the T cells, is able to activate the T cell so that the T cell becomes a killer cells that can destroy that protein, the lymphoma cell, and can also multiply. And so once you insert a certain number of T cells, if you look 2 weeks later, there are thousands more of those T cells that are all the same.
So basically what we're doing here is we're taking someone's own immune system, their own T cells from their body, and we're giving them a little bit of an upgrade,
exactly,
if you would.
Yeah.
And is that what's being done right here?
So
take us through the lab here.
This is a so-called PCR machine.
Okay, what is that PCR? What's that stand for? I'm sorry, I put you on the spot there. We'll look it up. We'll get it to you.
It's a process of amplification of the DNA. So as I said, these are pieces of DNA that have to be put together to make a DNA chimera that will make a new protein, right?
Okay.
So you take those DNA pieces, you amplify them in this machine, and then in the lab you literally glue them together. And then once you have this protein into a virus vector, it's called a vector, a viral vector, that is what you use to infect the T cells. And we can do that in a hood.
Go ahead, let's go in there. I'll get the door for you.
So these are sterile hoods where basically we use to work underneath this area that is completely sterile, nothing gets infected.
Right.
So you can work with cells and tissue under there, and you take these T cells, for instance, and that's where you will do the infection. So you take your virus that contains the CAR, put it together with your T cells, infect the T cells, then you can test them using other machines in the lab, make sure that the CAR is actually there, it's actually expressed, and that's the product that you will purify and give to the patient.
And the idea is this would be where the final T cell with the protein is grown and matured here, and then it would be reintroduced to the patient where those cells could then go off and fight the present lymphoma cells, correct?
Exactly.
So at this point, we are talking about preclinical trials that you're doing here at Memorial Sloan Kettering. What is CAR T cell therapy currently approved for?
So the indication right now for lymphoma specifically are for diffuse large B-cell lymphoma or for transformed follicular lymphoma. So that follicular lymphoma that has transformed to a diffuse large B-cell lymphoma, so it's become more aggressive. The other types of lymphomas like mantle cell lymphoma or CLL with Richter's transformation are all being tested. Follicular lymphoma even is being tested in clinical trials, but they've not been approved for treatment with CAR T cells.
How big of a breakthrough is this? Because we've been hearing a lot about CAR T cell therapies lately.
I think it's huge. I think it will eventually completely revolutionize the way we treat lymphoma. I think we're in very early stages, and obviously they need to be improved. The response rate right now, if you look at the 1 year or 2 years responses, it's about complete responses, it's about 40% for all three products that are being tested in the biggest clinical trials. But obviously we can do much better than that. So the newer trials are now testing CAR T cells plus something else that could be a small molecule inhibitor or another immunomodulatory protein. So we basically want to make those CAR T cells better. And what we do in these labs here and in Dr. Sutherland's lab, Dr. Brenchen's lab here at Memorial, we are basically making the CAR a little bit better. So we are now talking about armored cars.
Gotcha.
So, cars that are a little bit more powerful.
So we're going to have tanks eventually going in,
exactly.
T cells that are going in and beating up
exactly.
all of those lymphoma cells that are in there. I just want to do one more reset for the people who are watching on Facebook Live. You're watching the Lymphoma Research Foundation's chat on immunotherapy. We're using the hashtag LRFIO chat, and we are here with Dr. Palumba at the Memorial Sloan Kettering Cancer Center labs, where we are learning about some of the cutting-edge research that is going on here. Now, Dr. Palumba, we've been talking about immunotherapies, and we mentioned, Dr. Zelenitz earlier mentioned that with rituximab patients, it's a 10-minute procedure, and they're in and out. What is the common standard when it comes to these immunotherapies for patients? Are they able to go out of the hospital right away? Do they need care afterwards? How is the quality of life while they're receiving this treatment? So
for CAR T cells specifically, it's very different than just getting a monoclonal antibody infusion. First of all, there is a period of time in which the cells are actually being manufactured, right? So you take them out of the patient and then they fly to Seattle or New Jersey in the facilities where the cells are produced, right? So the facility will receive patients' blood cells, and those blood cells have to be infected with the virus that has the CAR. That process actually takes anything between a week and 4 weeks. After the process is complete, there is a period of quality control because they have to be tested to be perfectly viable, number one. to not be contaminated. For instance, today I just got news that one of my patient's products was slightly contaminated with some particulate matter. And because of that, they need to be reproduced. So obviously this could be a problem because we are in that waiting period in which a patient, which usually is referred to us because they're sick, because they have failed previous therapies, so now they don't have a lot of time to wait.
So CAR T-cell therapy at this point is being used in more extreme situations?
Yes, I think that will change. Okay. But right now we're using as second line, third line, fourth line of treatment, and so patients need to be treated relatively quickly, and so we need to make sure to make that production time as short as possible. And as I said, right now the shortest that it can be is 3 to 4 weeks.
Right.
So in that period, the patients need to be treated with something most of the time. Some patients have the luxury to actually wait and be observed for those 4 weeks. But a lot of patients actually will require a cycle of chemotherapy.
And so while they're going through that chemotherapy, is it the standard that you would see in other chemotherapy treatments? We heard Dr. Zelenitz and you mentioned earlier that sometimes these immunotherapies are given in conjunction with chemotherapy. Is that the standard?
Yeah, so depends. So the new chemotherapy, the new therapy that they will receive could be chemotherapy, could be immunotherapy with a different antibody that they had not received before. If, for instance, they've always received rituximab in the past, maybe that's the time to switch them to obinutuzumab, right? Or many of the new targeted therapies are available, and those are actually the ones that we really like to experiment with more because they are the most promising. So these are not immunotherapy per se, but they're new targeted therapies for lymphoma.
When you speak to your patients or people who come in and might have questions about lymphoma, their family members at this point, what questions do you tell them that they should be asking about immunotherapies when it comes to their own treatment?
So again, if they can't refer to me for CAR T cells, they should be asking me what the side effects are. I think that's the most important thing because some patients might not be able to tolerate the side effects. The side effects can be quite severe, not frequently, but there are two different types of side effects that we see almost all the time. Something called cytokine release syndrome. So basically you have this T cell that is now a powerful part of the immune system, and then you have the lymphoma cells, and they go together. The lymphoma cell will die, and there is almost an explosion of substances that are released in the blood and can make the patient very sick, from fevers to low blood pressure to just feeling poorly.
How does that compare to the side effects of other immunotherapies that are out there?
Right, so compared to, let's say, an infusion of rituximab or of obinutuzumab, those reactions are instantaneous. So you get them as the drug goes in, but you can stop the infusion and give some Benadryl or Tylenol or steroids, and the reaction will go away. In this case, it's a little bit more complicated. They can last longer. Some patients end up actually, needing to be in the ICU for close supervision with these side effects. But the good news is these side effects are actually most of the times reversible. So we know how to treat them. We have 10 years experience at Memorial giving CAR T cells. And so we have learned over the years how to manage these side effects, and we're very good at it. And nobody does not get out of the ICU for this, from CAR T cell infusions.
So what resources do you point your patients to for more information on these immunotherapies as they're learning about their own treatments?
But there is a lot of, first of all, that can be found online. We have brochures that we can provide. We have a huge group of people that we work with. There's an enormous help from the nurse practitioners that work with us and the research nurse that work with us. There is a big CAR T cell nurses group, and they really do the teaching, the day-to-day teaching, what to expect when you're going to get the line from which we're going to withdraw your CAR T cell, your T cells to make CAR T cells, what to expect when you are starting to feel a little bit confused and maybe you're about to develop a neurotoxicity, or can I test your memory now and 4 weeks after receiving the CAR T-cell to make sure that nothing has changed and you haven't developed any neurotoxicity.
Right.
So it's a giant operation that requires a collaboration between many groups at this place and all the places that do this procedure.
You mentioned that you go online and there's a ton of information out there. There's also a lot of misinformation, and I feel like we've all done it. We've gone online and we've Googled something and found something that made us maybe more scared than we were in the first place. So what myths are out there maybe about immunotherapy that you'd like to dispel, if there are any that pop to mind? I
don't know particularly about immunotherapy, but there are a lot of myths about, for instance, high doses of vitamins. A lot of patients see doctors who give them IV vitamin C in humongous doses, which we know are completely useless and might even be harmless, actually. So I always actually recommend my patients to go online to look for, the LRF, the LLS, the American Cancer Society, the Waldenstrom Foundation. I know exactly where they should be looking, and that's what I tell them to do. And being here at Memorial Sloan Kettering, you are on the cutting edge of some of these clinical trials and the research, the preclinical research that's being done here. So what are you excited about when it comes to lymphoma treatment and immunotherapies? I think what I'm excited about is that I have the fortune of working in a place where I can continuously improve what I do right now. So I know that the CAR T-cells that are currently available are a great step forward, but we're not there. And I work with the people who actually make them better. So from this lab to Rainier to Michelle's lab, they are working every day to change them so that they're going to be a better therapy. And I am sure that that 40% response rate that we have right now can easily be brought up, to 60 and maybe even 100% one day. But we're not there yet, but we're working very hard on it. And so with that being said, what final message would you leave someone with who might be newly diagnosed, or their family members who have someone close to them who is newly diagnosed, about their diagnosis and their prognostication looking forward? Yeah, so I think that the most important thing is to make sure the diagnosis is correct. And so the review of the pathology by a group of expert hematopathologists is fundamental. So coming for a second opinion is very important, particularly because besides looking at the patient, the scan, and the available clinical trials, we also confirm the diagnosis. So having an initial evaluation that includes all of that is fundamental. It's really, we're not talking about metastatic pancreatic cancer, right? So this is a disease that actually has a lot of new therapies coming up, and the prognosis for certain type of lymphomas is actually excellent, and patients with some type of lymphoma have the same lifespan as me or you, the people in their age group that don't have cancer. So even though you might be living with lymphoma and not be what we would call cured, the quality of life is at a point where the death at an older age might come from other causes. Exactly. At that point, so absolutely. You can live with lymphoma. Yeah. Quality of life. Doctor, thank you so much for your time today. We really appreciate it. Thank you for the tour of the lab and for all of the information that you shared with us. You're welcome. It was an absolute pleasure speaking with you. Thank you so much. And as always, for more information on immunotherapy, you can head over to lymphoma.org. We also have the LRF helpline, which is a fantastic resource for both patients and their family members. And please don't forget to like, follow, and share this video if you find it helpful, because spreading information is the way that we are going to help patients and eventually find a cure. Thank you so much for watching. On behalf of the Lymphoma Research Foundation, I'm Joe Messeri. Have a great day, everybody.